cancel it? Oh, there
No,
it goes. There it goes.
no, yeah, I think it took a little bit to. Okay, one live. Yeah, I was wondering on if the ticker was ticking or something like that. So I was like, Brad, I know you're on call. Like, then how do I go live? Then can everyone hear me?
Yeah.
No, okay.
Yeah. So you might as well, you can go mute for the next few
Oh,
minutes
yeah,
and
I should
I'll introduce
mute.
you.
Yeah, I should mute. But hi, Amy, can you hear me?
All right. It looks like the attendee count is slowly tapering off. So we'll go ahead and get started. Um, welcome to our CortiCare webinar on neonatal EEG. I'm Brad. I'm just moderating here. You see Mike on your screen now. He is the one presenting. Mike's been with CortiCare for quite a while now. He has 20 years of experience in the field and has worked particularly with pediatrics and neonates. So he's a wealth of information on this topic. So I'll go ahead and hand it over to Mike. You got to unmute yourself, Mike.
That's where I was double checking
There
on
we
if I was
go.
muted or if I was muted or unmuted. But no,
Yeah.
thank you, Brad, for the nice words and the introduction. And more so, welcome everyone on hearing me talk for an hour on a topic in our field that I'm very passionate about. Like, I find neonates fascinating, but also uh, difficult and part of your job that like you dread. But first things first, like I got some polls. I'm kind of just curious on more so like for the audience, like how long have you been in the field of neurodiagnostics? I'm hoping this works out. Did it pop up? Shit. Uh, well, polls might not be working. Okay. Well, if the polls aren't working, then I'll just jump into my PowerPoint. And we'll just go through this presentation I made. But more so, the agenda is like why neonates are neonatal EEG is so difficult. Kind of go over kind of some similarities and more so the differences between basically adult and neonatal EEGs, learning, and then a small conclusion. More so, I'm going to be really focusing not as much on the waveforms as pretty much everything you will be doing prior to you start getting waveforms, what the environment looks like, what you're going to be doing, hookups, and all that. Um, More so reasons why I find this topic very important. This topic is I'm trying to really bring awareness to everyone that the neonatal population, for either those who do it or those who might do it in the future or those who have never done it, it can be a very daunting task to do an EEG on a neonate with everything that is going on in the room with the patient or your surroundings. And this is where assumptions can get us in trouble on thinking that a neonate is no different than an adult. And more so for all of you who do it, I really want to show like my gratitude and appreciation. If you have never heard it before, like I thank you all for all of you guys and what you do, because I know and I recognize that this is a very difficult population to perform an EEG on. Uh, but like, why are neonatal EEGs so difficult? There's a lot of reasons, and I've kind of tried to figure out like why individuals find this difficult. One the first things first is not a lot of experience working in this population, or if you were educated either on the job, one year certificate, 2 years associates, or 4 years bachelor's, you do not get a lot of experience working on this population. Most of the work you will see is on the job or particularly on the patient. Fear of the unknown. A lot of people have heard that neonates can be difficult, or like just looking at it, it's drastically different, and a lot of people don't know what it all entails. It can drastically look different for from an adult, whether if it's the environment of the ICU, an EMU, or so on, the hookup, and then the EEG, and then mainly like along with the EEG, there is a lot of artifacts that come with this population. But some of the areas I'll be really focusing on for adults and neonates is reasons why you would do an EEG, the hookup, the environment, the EEG itself, and hopefully if you walk away from this, like some tips that you might be able to take back to your hospital or bring up to other individuals on like how you can learn to be better at neonates. But first things first, same and different. We're since the same is probably a quicker review for me to go over, and I kind of decided ultimately we're just going to go through the common 5 W's: who, what, when, where, and why. On the same. Who are we going to be doing these EEGs on? Patients in the hospital, whether if they're in the ICU, the EMU, or the general floor. Normally, they will always be a patient that is in the hospital. I know that like either ambulatory or there's other facilities that you could be doing EEGs, but these are the ones like we're going to specifically focus on, just because the neonatal population is mostly focused on or in the hospital. And then what are we doing? We're doing continuous EEG monitoring. When we are doing it when an order comes through, whether it's from a doctor, a fellow, resident, PA, NP, and so on. Just when some medical professional feels like continuous monitoring is needed, where the hospital, specifically EMU, ICU, or a general floor, and then the why. This is where if you aren't really focused or have an idea on like why, the reasons why we do continuous monitoring for either an adult or a neonate are very similar. Either trauma or injury to the head, suspected seizures, event cap verification, and then protocols. A lot of the protocols for the neonatal population are protocol driven. Cooling protocols, like for adult versus neonate, there are cooling protocols that are very similar on why you would do it. It's just because of an injury or a traumatic event that happened in that patient's life. But more so, those are all really the similarities. But like after that, like when you really start digging deeper, there are different there are many differences between the neonates and the adult population. And this is where I'm pretty much going to start focusing on the differences in the neonates and pretty much start from when you get that order. Where are you going to get an order, or you need to do continuous monitoring on a neonate? First things first is you're going to be going to most commonly a neonatal ICU. And this is where, if you're not very familiar with the neonatal ICU, it can be daunting when you walk into that door and see all this equipment. Uh, some of these pieces of equipment are very common that you see: IV pumps, pulse oximeters, vital signs. One of the bigger differences is what the patient's in. Unlike the traditional bed that a lot of us learn to hook up patients in the ICU, neonates come in many different sizes, whether if it's a heated bed that I'll go over more, a little isolette, or a smaller bed. There's where these are many different things that a neonate could be in. And also, this is where if you really look at this, where this patient is in, or any of these, like it can be daunting. How many hookups have you done from the side of the bed? Unlike with adults, where we try to navigate to the back of the bed so we can work from the patient being below us, there's no way you will be able to maneuver yourself to the back or the top of the head to place all the electrodes on. And that's where, if you're not very familiar with hooking up from sideways, this can be a daunting task, because it's definitely different than hooking up from the top. It's harder to get your level planes of going in line with your electrodes, and you might feel like you're just backwards. Or for some patients, especially in the ICU, you might have to move from the left side to the opposite side to do the full hookup, just because you may not be able to turn this patient. Unlike when you are trying to do the hookup from the top, you typically can get access, but in the neonatal ICU, you might not be able to just because of all this equipment behind the patient. And then more so, this is a different bed. We'll just call it bed. A patient can be in. If you're not very familiar with this, all the individuals who work or who have been in the neonatal ICU, these are incubators or isolettes, which can be very difficult to try to do a hookup. You might have to work through these holes just because you're not able to reach the patient or have free access to the patient as you would typically do, due to many factors on why the ICU may put the patient in one of these isolettes. Along with that, the isolettes are probably one of the hardest things to figure out where you would put your EEG machine to get a good camera angle. There are these plastic walls that are put around the patient where it can be very difficult to get a camera angle. And as you can see in this picture, you can see that partially the border or this bar, it is blocking the patient. So I kind of wouldn't suggest this angle just because you don't have a very good angle to see this patient. And then along with that, a lot of neonates are wrapped up in blankets and so on to keep them warm or to keep them swaddled. And this is where also to sometimes in the neonatal ICU, they will cover up the isolette with a blanket just to try to make it darker and easier for the neonate to kind of rest and sleep. But the problem with that is there's a blanket over the site. You will not be able to see the patient. And being patient is one of the most important things when you are performing long-term monitoring or EEG monitoring, being able to identify and verify if there are changes on the EEG, is the patient doing anything, is so important. And that's where it can be difficult to find the perfect angle to it, along with like camera position of the machine. Also, as you can see, there's not a lot of real estate on to work around the patient. If you put this machine right up next to one of the sides, it's practically very difficult for either nursing physicians to examine or work on the baby because the EEG machine will be in the way. So this is where a lot of discussions with the ICU floor, the nurses you're working with, trying to ask them like, where would be the best angle position for the camera or for your EEG machine, so that way nursing can still perform what they need to do, but we can acquire both the EEG and video. And that's where, for sometimes, you have to remember our EEG cameras, they do not need to be right up next to the isolette or the bed that the patient's in. There is a zoom on the camera. You just need to try to reposition it or angle it to the point where you can get a good camera angle. You might have to raise the camera a little higher to get a better angle, but you do have a lot to play with the camera on getting a good camera angle instead of just trying to position it right next to the isolette. But this is where it depends really on yourself, the type of equipment you have, and the options you have. Thinking of other ways to position things will help you and everyone else on performing this monitoring. But this is where the neonatal ICU is one of the most equipment packed places in a hospital with not a lot of room in there to basically have another machine. But as you walk closer, then you start kind of discovering where the patient is. And this is the prime example if you are working with a patient in an isolate, working with your arms through holes. And this is where this can be a daunting task or very difficult to perform due to the fact that not a lot of people have experience doing it, or like this is where you're just it can be different. So a lot of experience will help out in performing this, but also if you are currently working in one of these units, talk with the nurse. The tops can come up or the sides can come down. This is where I will suggest like always verifying with a nurse on what can and can't you do to help you out on making the hookup the easiest as possible. New I have up in a parent's arm because it's very difficult to get them part to have a new parent part with their new child. So this is where being very mindful, like ask and discuss things than anything else. If you've never worked in one of these, this is a warmer. A lot of neonates are in just because they are unable to keep their heat or maintain their temperature. One of the biggest concerns and a lot of people working under these, if you put your head underneath it, it does feel like your scalp is burning just because you have all this spontaneous heat coming down on you if you're over the neonate's head. But another problem is the quality of your EEG. Unlike traditional EEGs, if someone's being warm, normally they have a vest or something that's around their body. For neonates, there isn't much like that, or they use ambient heat to keep them warm. The problem with ambient heat will melt your paste. And if you are wondering why the quality of your EEG is starting to change when normally you don't have to fill, replace, or so on your electrode after a day to 2 days, this may drop that from a half a day to a day. These baskets I bring up because I have done a few hookups in these baskets, and I find these the most difficult. It may not look like it's difficult to do a hookup, but this is where these baskets are at waist high, and the baby is always inside of it. So trying to work with kind of you hunched over the side and then trying to reach down to put the electrodes on, it's very difficult. This is where like think about like hooking up a 2-year-old or a peds patient in a crib. Normally we always lower the sides of the crib, but like could you imagine like if you're not unable to lower the sides of the crib and trying to do a hookup? These ones I have found like the most difficult, these baskets, just because it's hard to maneuver, hard to get your position to put the electrodes on. It's hard to turn the heads or reposition. And then also we commonly place either pace 1020 or our supplies either on the surface of the bed or something or somewhere else. These ones, there isn't a lot of space for you to put anything. So this is where these ones can be quite challenging in the hookup. But as you get closer and like see this neonate, this is where if you've never, this could be a daunting sight to see that the neonate could be quite small. Head circumference, this is a kind of comparison of a neonate to this play doll. All these examples are all on the internet. And I find the internet a very good resource nowadays to help out on just getting another place for a resource. But as you can see in this picture, for this neonate is hugging this bear, and the bear is almost about the same size as the neonate. And if you can see this comparison to an adult, this neonate is almost it can fit into the palm of this nurse or medical individual's hand. So this is very small than anything else. And then you kind of compare a normal adult hand or a parent hand versus the size of the head. The neonates can be quite small or premature. And this is where, along with the prematurity, the heads are smaller, immature skin, or their skin is very fragile or delicate, which can make the hookup or to lower the impedance is very difficult. It might take more effort. It might take some patience. You might have to tackle it a different way than you would do with adults, because this is where the common way you would always prep, m- it might cause sores or prep sores on these individuals or these neonates just because of their skin and the immaturity or the fragileness of them. Along with the fragileness is their skulls are a lot different than adults. The and I think I go over that further in the next slide. I think it's in a couple of slides. I'll go over that. But this is another common thing: assisted breathing. As we all know, we deal with a lot of intubation tubes, O2 support, and these are very common for all of us on what we see in the neonatal ICU, either in the adult ICU or the neonatal one. And these shouldn't surprise anyone if they walk into and see a neonate hooked up to one of these. My next slide, this is CPAP. If you never knew that they create neonatal CPAP, they do. One of neonatal CPAP is one of the darndest things to see or to try to perform an EEG on, because you really need to discuss this with the nurse on like what can be done, or can the patient be off the neonatal CPAP for either an extended period of time or just the amount of time it takes for you to do the hookup. These are patients that can be very difficult with this piece of medical equipment just because of the assisted breathing. But another thing that might not come across to you, or I'm bringing in awareness, is that once you are done with your hookup, and if they're going to put this on, you have to be very mindful about this cap or whatever they're using to keep the CPAP attached. Since just because the head wrap could be a very taut to the point that it could be leading to increased pressure on the electrodes, which could ultimately lead to pressure sores. Some of the worst neonatal pressure sores I have ever seen more so wasn't from a head wrap from the EEG department. It was more from a medical device, because the nurses did their normal thing. They did their normal wrap, hat, or so on. But the biggest problem with their normal what they do to use this device, they're not very accustomed to using it with EEG electrodes underneath it, and that's where we've all slept on something that you weren't supposed to sleep on, or had something on our heads that made it uncomfortable. And this is where for the neonates, it's it's hard to tell on like if the EEG electrodes are pressing too hard. It's hard to tell if the baby's crying because of other things versus EEG till you discover and take off the EEG electrodes. So this is where I bring awareness to, if any of you have to do neonates and have a CPAP machine, to really have that discussion, or make sure that like more so in the future, this is a tool the neonatal ICU can use to help assist breathing with neonates. Another machine that you may not see a lot in the adult population, but individuals who are either on this talk, I assume you are very familiar with an oscillator. If you are not familiar with this machine, this is one of those machines that I dread whenever I saw it in the ICU. More so, it not dreading, like hear you can hear it if you're walking in. This constant pitter patter of the machine can cause a lot of artifact and problems to the EEG. The oscillator is used basically when uh, an infant just fails conventional ventilation, CPAP, intubation, and they have to resort to this just because it is another tool that the ICU will have. And a lot of these individuals who fail kind of traditional ventilations are more so the preemies who don't have very mature lungs or the ability to breathe. And that's where this also helps is a protective ventilation method. But also, this is one of the hardest machines to either do an EEG on or the amount of artifact it causes. This next video, this kind of shows you what will happen to a neonate when they're on an oscillator. And as you can see, there is constant vibration. If you are familiar with adults with tremors or other things, you can see like by this tremors alone, like can you imagine like a neonate intubated, not very heavy, and this is constant vibration happening and seeing it on the EEG, either because of the artifact by the movement of the patient or the extreme artifact of the oscillator that's the EEG is picking up. And this is where, like, this is my only slide on basically EEG. This is an example of like what an EEG would look like with an oscillator artifact in it. And this one I actually find this is actually a good EEG. But as you can see, there's all this like extra erroneous, like fast activity going on throughout the whole EEG in specific areas. And this is where this was from the Science Direct on like this kind of measuring the frequencies that you would see. The common ones that you'll see from FP2 to C4 is kind of from zero point 0.3 to 70 hertz, or the frequencies you'll see. But then as you start moving farther down, more so when you have an oscillator on the one of the more common ones you are going to see below 80 hertz, 70 hertz, all the way up to or greater than 250 hertz. And that's just the constant ventilation or the machine just working on overdrive that the EEG will pick up. And these are frequencies you will see on the EEG. But as we start moving closer and looking at this neonate, a lot of births do cause these can lead to partial trauma in being stuck in the mother's vaginal canal and can cause misshaping of the head. If you always thought that after a baby's born, that their head is always perfectly round and stuff, it's more less common than not, especially with these patients that have trauma or have been caught in the birth canal that they need to be more helped out on being pushed out or have to be the doctor has to use some tools to get the patient out. This is where like could you imagine trying to measure this using 1020 with this extra misshapen or swollen head? This is where traditional 1020 measurements can be quite difficult and the leads might be off a little bit. So documentation will be very important on writing in if the head is possibly misshapen and stuff. And this is very common with this population on misshapen, just because for the neonatal population, their heads or their skull is not fused. They are more so like plates that can be positioned and around. And then more so, if you would push down on a neonate's head, you can tell that it's not a firm skull in comparison. And that's where this is to help with the birthing of the neonate. But then that's where like neonatals' heads can be misshapen. First wash is another one I bring up a lot. And for us, that especially when we're doing hookups on neonates because of cooling and trauma protocol right after delivery, neonates don't have their first wash or have not, or there has not been time for their first wash. And as you know, there's time ticking that EEG needs to be up and running, and the patient needs to start to be cooled. So there is times where this patient might not have a first wash. So that's where it can make the hookup very difficult, just because there's mucosa, blood, and other things on the head that could make either application of the electrodes, reducing impedances, or keeping the electrode in a spot very difficult, whether if you're using 1020, any of the sticker tape kind of stuff, collodion. It can make it very difficult to have that adhere to the patient's head. Along with that, I do give warnings about like ultrasound too. They can be notorious about coming by, doing a head ultrasound, putting their gel right on the fontanelle and not wiping it off too. But one of the good benefits on the neonates is that they do not have a lot of hair. So that's where some of our traditional problems on trying to apply electrodes, or if it's never been brought up to you on like different techniques that you can try some different things, just because hair is a difficult thing to try to deal with when you're applying electrodes. And this is where, with not having a lot of hair, you might not need to worry about some of that stuff, just because in the with dealing with adults or working with adults, like to try to navigate through some of this stuff, it might be easier just to shave the head. This is where neonatal's hair is very fine, very coarse. It's easy to part, but there's not a lot of it too that you have to work with. So this is one of the more benefits, that you might be able to think about other ways to do a hookup, or tools or EEG electrodes that you might, or different electrodes you might be able to use that you traditionally don't use in the adult population because of hair and so on. And this is another possibility, that if you didn't work in the neonatal population, you might have never saw. Seeing a head IV could be a very breathtaking, wondering like how am I going to do EEG when there's a head IV there? Head IVs are one of the more common things you will see in the neonatal ICU, just because it is one of the most reliable ways the NICU or the nursing can get access, and it's one of the easier places to gain access, just because the vessels in the on the skull or in the head are a lot bigger than the ones in the arms. I don't know if a lot of you have seen nurses trying to get an arm IV, and they are small. They can be difficult in trying to access that, versus these vessels in the head. The biggest thing is, unlike traditional IVs, like this one's on the head, and more so we have to do EEG. Like, and if you're really doing double distance, like you really can't omit an electrode. Like for here, this would be over T3, C3. If you omit T3 and C3 and are using double distance, the only electrodes you'll have on the left side is FP1 to O1. There's nothing in the middle. So this is where you need to try. This is where I would not suggest ever omitting anything in double distance. An electrode needs to be put there. This is where I would suggest like seeing if you can kind of dig a little, see if you can put it under this 4x4, or I think it's a 4x4 under here, like try to lift up some of this tegaderm. This is where they don't need all this tegaderm. It's kind of covering up or taking up space, trying to peel some of it away so you can put an electrode on. But this is kind of one of the phenomenons that, like, if you've never seen it or worked in the neonatal ICU, I do not know if the adult population will ever see a head IV. I know there's shunts, drains, stuff like that. Those are a little different, just because you can omit some of those electrodes, just because you have surrounding electrodes to do the monitoring and things like that. But more so with like drains, bolts, and so on, like normally neurosurgery or other things, like they don't put this huge tegaderm to basically take up like half of the head. So this is where trying to be very mindful and talking with your nurse on trying to accomplish what you need to do on EEG. And this is where like you cannot put just like FP1 to O1. The EEG, you'll be missing this whole, practically this whole hemisphere on the EEG, which could mean you'll be missing a lot on the EEG. And then moving from there on, like now we're talking about just EEG equipment. I don't know, like traditional, you can use traditional 9 millimeter deep cup disposable electrodes. This is where I propose to some people, have you ever thought about 3 millimeter or 6 millimeter? There are smaller electrodes you can use to help out with your hookups. The biggest problem with those are it's less paste in the electrode, so it might dry out quicker, or the integrity of your EEG can falter on picking up more artifact and so on. If you've never seen one of these, it's kind of a quick hook BrainZ that it is a tool that you could use on a neonate. This is where, unlike with adults, quick sticker electrodes on the scalp won't really work as well due to the fact of all the hair. For this population, since their hair is so coarse and thin, or there might not be a lot of it, you can use this to try to get and pick up EEG. Or this is where also I think I have a couple pictures later that like you might be able to like use like stuff that you would use for a EKG as an electrode, instead of using the traditional plastic, metal, silver chloride, and so on. Electrodes are electrodes. They just need to be on the area of the part that you're trying to pick up electrical activity, whether if it's the traditional cup electrodes, metal electrodes, or stickers. They all perform the same task. It's more so the individuals or the awareness on like what you can use or what you can't, or thinking through things. Quick break connects are starting to become more of a common thing we are seeing in electro packages, or if patients have to go into be disconnected from the EEG so you don't have to do a rehook and things like that to help. But that's where like looking to see, being very mindful. The NICU is full of noise. After I've shown you all of these different apparatuses where the patient is and so on. So you need to be mindful of where your cables are, if they're properly connected properly and so on. And this is where for a lot of people, some people love them, some people hate them, or they don't have a really big opinion about caps. Caps, in the end, it's a tool. It really depends on the individual who uses the tool, and it is an option. And this is where I try, especially for this talk, just bringing awareness to everyone on what you can really do, or how can you really do a hookup. Are there other ways, just other than normal 1020 and things like that, or does metal electrodes, or are there other tools that help you out or make your life easier? So, and then this is where like we really talk about hookup. I really stress to everyone who is doing a neonatal hookup, like be patient and things like that. At the hospital I was at or oversaw, if you started becoming frustrated, upset, or just couldn't get it the EEG hooked up properly, or you were having problems, ask for help. This is where if you don't really see it on yourself, like your face will show that you're starting to be frustrated. And if people are wondering what's taking you so long or why you're asking for help, those individuals really have never done a lot of these hookups, or they do not, or they're very unfamiliar, because these ones, some of the hardest hookups I have ever done was in the NICU. the NICU is an environment, and this is where these hookups are very difficult due to either the environment, what you are working in, the isolates, what you need to do, family, nursing, and things like that. Impedances are so drastically different to trying to get it on a freshly 1 hour, the patient's only 1 hour old neonate than it is on either me, a teenager, or an adult. Trying to get those impedances down can be very difficult. Also, trying to figure out, like, based off this patient, how many electrodes am I really putting on? How many electrodes can I get onto a neonatal's head? There are very guidelines on standards on like when you should use suggested when you should use double distance to when you should use full 1020. And then, yeah, besides like how you're playing, what lab you're actually using, whether it's disposable, reusable, stickers, and so on. And then, yeah, trying to figure out how many. And like I showed you guys all before, like what is the BA? Oh, how am I the electrodes on? Is the baby in a crib, an isolette, a basket, or the patient's arm, or the parent's arms? And this is where, for everyone, if you've never really, like, really looked at or someone explained to you kind of head circumferences and electrodes, this is where I'm going to go do a deep dive on double distance and head circumferences. This is where this is 60 centimeters might be a bigger adult head circumference, but like this is a very common one, and I wanted to make the numbers very easy. And this is where for the inner electrode distance is always 6 centimeters if you had a head circumference of 60 centimeters. But when you really look at if you try to use a regular 1020 head circumference, 1020, and put all the electrodes there in a neonate that only has a head circumference of 26 centimeters, the inner electrode distance of each one is only 2.6 centimeters. There is not a lot of space if you try to put all the electrodes for a head circumference of 26 centimeters. Also, this is where like the possibility of bridging. Don't know. I assume all of us have those coworkers who use either too much, too much new prep or paste or too little. But this is where it could be very common that you get a bridge or flattening of the EEG. But only having an inner electrode distance of 2.6 centimeters, could you really tell the difference on if you have a bridge versus the electrodes are just too close? And you really can't see the difference between two electrodes. This is where, like, when we go back to basics, EEG is the difference of two electrodes. And that's where the difference being 2.6 versus 6 centimeters can be drastically different on the amplitude of what you're going to be seeing. So when you really start to introduce double distance, this is where taking some of those electrodes away does increase the distance of the inner electrodes between two electrodes, but also it does create the idea of like the EEG kind of looks partially more similar to an adult. The inner electrode distance is more closer to an adult than it is to like using a neonate at 2.6. There is less possibility of causing bridging just because the electrodes are farther apart, but the one of the biggest problems and the trickiest things with double distance, and this is probably where I'll probably do a follow-up webinar if everyone is interested in more so about waveforms and things like that, about neonates, is how the waveforms look when you increase the double distance and you increase amplitude. But one of the biggest problems with double distance is trying to identify activity or verify the activity that's on there. One of the main criterions, like when we talk about like monitoring, looking at EEGs, is evolution and spread. This is where when you only have half the electrodes, it's hard to say when you go from like a one channel to the whole hemisphere, if it goes to the whole hemisphere, on like is it lateralized or not, because you're only working with half the electrodes. Half the electrodes will make EEG easier to assess, increase amplitude, and prevent all this common mistakes that might happen in the EEG if you use all of it. But it does make the EEG different just because you don't have as many electrodes or channels that you will be looking at, and you really need to be more decisive on. You may It may be isolated just because the neonate's head is small, that a seizure may be only showing up in one channel or in a couple channels, but that's only because there's only a handful of electrodes that you're monitoring. So this is where like double distance does have its pros and cons. It does help prevent mistakes or accidental bridging and so on. But then also when you really are starting to look at the EEG, it can be difficult to monitor or try to make heads or tails of like what's going on the EEG. Is it a seizure artifact? I've only seen it in a couple channels, but this is also, remember, there are only a couple channels there too. So when you are really thinking about artifacts versus seizures, you really need to dig deeper on investigating and figuring out what it is. And then EEG application, always be mindful about how you're prepping. Prepping, you really need to find a touch very similar to adults. Some prepping works well on some adults, some of it doesn't. But for the neonate population, you probably should start softer and incrementally go up. You don't want to start harder because you might cause a sore. Yeah, your skin irritation, sores, and blisters, proper lead placement. This is where bundling, being mindful of things, and check with your facility. Normally, guidelines always want us below 5K ohms. This is where make sure that you we all have to remember this is a suggestion or a suggestion by ACNS to try to shoot for this, but this is where like can is it even physically possible to get it below 5K? I have had a lot of seen a lot of EEGs. Like everyone in the department tried, and all we could get is 10. We couldn't. The more we attempted, like we just couldn't get it lower than 10. So this is where verifying with your doctor, making the temp, and then knowing like this is where sometimes it's not on how low you get the impedances, is making sure that it's all balanced too. And this is end product of what you could see or how people would be working about it, like the brain Z, the cap, old traditional electrode. I think this is more closer to like a full term neonate versus this one in the isolate, all this paste and so on. I think that might be FP1, T4, and then one over here is probably O2. Like, as you can see, there's not a lot of space if you would try to get all your electrodes on, but then also there's all this extra pace that like can cause bridging if you're not being mindful of. And then more so, the byproduct afterwards. This is where I tell everyone really be mindful of your electrodes. At the hospital I was at, like I would not be able to leave the room if I had the EEG electrodes intertwined with all the ICU stuff. And this is where the patients will have a lot of stuff going on. So this is where like having good practices on bundling your electrodes. This is where I was telling you like this can be a viable option due to the fact that neonates don't have a lot of hair, that you can possibly use stickers to adhere and pick up the electrical activity. It's not unheard of on bundling, and this is where I don't promote this one on subdermal needles. This is where you guys and everyone, it's an option than anything else. But I I have never, in probably the 1,000 neonates, ever felt like I needed to use a subdermal for a hookup. But this is where this is an option, and just was speaking with a coworker, and she reminded me that like when a patient got transferred from outside the hospital to the hospital we were at, the electrodes were still on the patient, but that hospital transferred the patient with subdermals in. And ultimately, she had hindsight like, no, we're not going to keep these in. We're going to redo. It was nice of them to send us the electrodes and stuff, but then also, that's not, there's way too much possibility for error or harm to either more harm to the patients or to anyone around them, whether it's family, nursing, or the techs themselves, if you didn't know that there were needles in it. But these are all, this is where like I bring up like these are all tools, these are all options, sometimes trial and error to try to figure out what's working out best. And more so for me, bringing in awareness. Oop. I gotta go back. I accidentally took out a slide. Um, whoop, actually, forgot I took out a slide. It's where is it? There it is. So going from that and moving on, uh, learning, not just by doing. Uh, for all of you, like try to shadow, seeking education material. If you work at some facilities, like there are simulation labs, especially for the neonatal ICU, that you can go or you can clock time and ask around at your hospital that you might be able to like actually work in the environment of a NICU. Try to practice, even though you don't have neonate volunteers, like practice putting your arms through an isolette, trying to figure out where you put your machines. This is where at the hospital I was at, like in services are very helpful on things like just asking there. I guarantee you at the hospital you're at, there's probably a random isolette that you could borrow for an hour, bring to your department, and just practice and getting a dollar, just practicing, just putting your arms through, trying to think through the process of doing things. The internet is a phenomenal new tool out there right now that you can use and find a lot of information. All my images that I put into this presentation came from the internet. But then also, this is where I will warn everyone. If you're very familiar with the guidelines and things like that, this is where for the ACNS guidelines and so on, the neonate population, it's its own population. So you need to be mindful of what those guidelines are. If you're not familiar with it, like brush up and make sure, because this neonatal population is its own population that you will have to perform the EEG or continuous monitoring on. But more so in conclusion, EEG is EEG. There's a lot of similarities and a lot of difference. The biggest thing is knowing these differences, not making assumptions, really digging deeper, and so on. Gaining education, knowledge, and experience. This is where I do say sometimes experience shouldn't always be on the patient. And for this population, and learning on how to do neonatals, a lot of it is, but there are ways to gain experience through that, not just by doing. And that's one of the biggest things I'm a big advocate on for this population, because when it's difficult or when it can go wrong, it can go very wrong very quickly. That's it for this presentation, webinar. But this is where I wanted to let everyone know, ASET is in a few weeks. CortiCare will be there. Brad, myself, Navita. If any of you guys are going to be attending, ASET, like come by our booth. It's 603. Let us know if you have any ideas, suggestions about like these webinars or anything you'd like to hear about, know about, and so on. Also, if you didn't know, the CortiCare has a podcast. We will also be doing podcast recordings and stuff there with Gil and his team. But more so, if any of you that's going, like, come say hi. Would love to meet any of you in person, answer questions, and so on. But thank you all for attending, listening to me talk about neonates for an hour. Does anyone have any questions or or anything like that in the chat or
There
anything?
is one
Or
question in the QA section.
oh, it's in QA.
Mhm.
Oh, there's an actual QA.
Yeah.
If a patient did, yeah, if the patient didn't have a first watch, what can be done to ensure the proper application of electrodes and a good reading? So that is a good question. If there wasn't a first wash, this is where I would tell you probably treat it no different than like when you're in the adult population and a patient shows up with a lot of oils, grease in their hair. You probably will have to prepping can get you there, but like this is where like I don't know if people like carry alcohol pads or something. They're probably going to have to alcohol each area to help you with getting rid of some of that stuff. You will not be able to ask like nursing to give a bath because if you wash the patient's hair, we're just replacing the first wash with something else that you have to wait to dry or things like that. So I would suggest more so like alcohol pads, cleaning the areas with that. It's no different than this, yeah, grease or oils. That it's just making the impedance to lower a lot difficult. This is also like if you see something, talk with a nurse and ultimately see what the urgency of the EEG is. If you're following the very particular cooling protocol, you may want they the hookup has to happen right away. But if there's not, uh, if this is just a routine or if there are event classification or things like that, you might be able to persuade the nursing to like you might be able to give nursing an hour to do the wash and dry. But if you can't persuade them just because of the urgency and stat, I would suggest trying to treat it no different than when you would what you would be doing when you're coming across grease, a lot of oils, hairspray, stuff like that. Normally alcohol pads because alcohol pads will dry up as soon as like they kind of clean the area and then they won't be there very long. But I hope that answered your this person's question or Marissa's question. Uh, so Michael's asking me what's my take on AEG needles. AEG needles. Are those the press-ons or a different one? AEG. I'm I will say needles. I have done them in my lifetime. I've done it a few times, but with those individuals, I've only done them because I was not left with any options, and those were individuals that pretty much 90% of their skin was burned, so I had to use something sterile to reduce infection and prevent stuff. So that's where like if you're not very familiar with needles on like you really shouldn't try to use them when you're put in that situation or if you want to speed up a hookup because this is where like after you put it's very easy to place a needle but then more so thinking after that what do you do next, do you cover it up with your normal things that you cover up the needle either the Hepaflex tape or something else, regular tape, or do you staple them in to make sure that they don't fall out? So that's where like you have to warn all the nursing who will be, because with neonates, very similar to adults, repositioning electrodes fall out all the time, especially how aggressive sometimes nurses can be. And especially with the neonates being passing a neonate around between nursing parents, especially with needle electrodes, it could fall out. So that's where I've done them. And this is every time I do it, I do really think about like, is this the best way? Because I think when I dealt with it with burn patients, like I used needles and I stapled them in because couldn't use the normal Hepaflex tape or something to hold them in because you can't have adhesives on burn sites. So but that's the quest. That's how I feel about needles. Wondering about frequency responses, characteristics of. This is where I know it's an option, and I'd be curious on too, Becky, on like if the frequencies were different on basically a sticker pad versus a traditional electrode. In theory, it doesn't sound like it's very much, and I don't know if any of you have ever done. I've done it a few times where I've placed for FP1 to FP2, I've used a sticker instead of a traditional metal or plastic electrode because this is where electrodes are electrodes. They pick up activity. I don't really know if there's a real big difference between traditional metal, disposable plastic, or a sticker. It just has the disposable sticker electrodes. But this is where, like, if you're gonna think about trialing it, like, try to see. This is where sim labs or like just an in-service, just trying it out. You could practice it on like adults, FP1, FP2, T7, T8. The biggest problem with trying to use stickers on adults, especially like with females, it's all the hair. You can't get a flush connection with the scalp, and normally hair pushes up, or it just makes it hard to keep the electrode on flush with the scalp. And that's where for the neonatal population, not having a lot of hair and coarse hair can do that. Your take on EEG needle placements with electrode 1020 placement. And that's where I think Michael, I was talking about like, yeah, my take on needle electrodes, like it it can be done, but this is where also, and it does, and the companies do advertise it that it can be done. The biggest thing is you taking the time and effort. This is why I suggest like bringing awareness and the pre-planning on things, because you should have a protocol if you're going to use needles, or a procedure. You should figure out if it's a standard of care or not. This is where for needles, like, it can be done, but then this is also where verifying with the manufacturer product on how long a needle can stay into a patient. Though this is where some people kind of overlook some of these things or may forget about, like, the manufacturer suggests, I think for needles, like really not longer than 12 hours, I thought. I'd have to verify and look at that. And that's where for continuous monitoring, especially in the ICU, like with babies being cooled for days. So are you going to go back and replace those needles at 12 hours? Because I don't know if needles are really made to up until a day. I know probably not past a day. But that's where, like, being very familiar with what your options are, the tools that you can use, the bringing it up, and that's where, like, for all of you guys, resources, CortiCare. My email is Michael B. At CortiCare.com. Like, this is where bringing up networks, asking other people, learning about things. There are other options if you kind of look a little deeper or kind of venture off in that. But no, but this is where final call on. Does anyone else have any questions, chat, or any help with anything? But if not, then thank you all for listening to me. If any of you guys are going to be at ASET, come by, say hi, give us some feedback, good, bad. Also, for the ASET CEU, you will after this, probably between today and tomorrow, you'll get a survey questionnaire about things, and once you fill that out, give us your asset number. You should get a certificate from us, and then we'll send your name and number to asset for your guys' CEU. But this is where, for that questionnaire, like, be brutally honest with me, my presentation ideas, and so on. Would love the feedback, and then more so topics you guys want to hear about, because this is where would love to kind of pass on knowledge, or just start discussions, or have you guys listen to what you guys are more so interested in. So, but wherever you are, I know sometimes we get people from overseas, or the people in the US. Thank you all. Have everyone either have a very good night, good morning, or good afternoon.